Can a simple full blood count give us a clue that a patient may have an H. pylori infection? It is an interesting question because the full blood count, or FBC, is one of the most routinely requested laboratory tests. It gives us information about red cells, white cells, and platelets. But can those routine numbers tell us anything about a completely different condition, H. pylori infection? Today, we are going to investigate that question using real laboratory cases. For each patient, we will look at the FBC first. I will make a prediction before revealing the patient's H. pylori antigen result. Then we will compare the prediction with the reference result. Before we begin, there is an important distinction. The FBC does not diagnose H. pylori infection. Our reference result will be the H. pylori stool antigen test. What we are investigating is whether particular FBC patterns are associated with H. pylori positivity, and whether those patterns might contain useful information for prediction. That is very different from saying that one abnormal blood count result proves infection. So this is an experiment in clinical laboratory reasoning. We will look at the pattern, make a prediction, reveal the actual result, and gradually ask whether the pattern holds across more than one patient. Let's begin with the first case. The question is simple, but the answer may not be. In the next episode, we will explore why H. pylori might be related to full blood count parameters in the first place.
Why would a stomach infection have anything to do with a full blood count? At first, that may seem like an unusual connection. H. pylori lives in the stomach, while the FBC measures cells circulating in the blood. The possible link is through inflammation and iron biology. The proposed pathway begins with H. pylori infection. H. pylori can be associated with chronic gastric inflammation. That inflammation may affect iron absorption, iron availability, or the way iron is used in red cell production. If iron becomes less available for red cell production, the bone marrow may produce red cells with less hemoglobin. This is sometimes described as iron-restricted erythropoiesis. That process could potentially influence several red cell indices, including hemoglobin, or HB, the red cell count, or RBC, hematocrit, or HCT, mean corpuscular volume, or MCV, mean corpuscular hemoglobin, or MCH, mean corpuscular hemoglobin concentration, or MCHC, and red cell distribution width, or RDW. But notice the language we are using: possible, potential, and associated with. We are not saying that H. pylori always causes iron deficiency. We are not saying that every patient with H. pylori will have anemia. And we are not saying that a low MCH or MCHC identifies H. pylori. Published studies have reported associations between H. pylori infection and iron deficiency infection. However, findings across studies are not completely consistent. Different populations, study designs, nutritional backgrounds, disease patterns, and laboratory methods may all influence the results. That uncertainty is exactly why the laboratory cases are useful. If a biological pathway is plausible, we can ask whether its expected patterns appear in real patients, and whether those patterns are strong enough to be useful. In the next episode, we will define the FBC parameters we are watching across the cases. A possible pathway gives us a reason to investigate. It does not give us the answer.
Before we start making predictions, we need to decide exactly what we are going to watch. The full blood count contains many measurements. Some describe red cells, some describe white cells, and others describe platelets. For consistency, we will use the same checklist for each case. First, the red cell parameters. We will record hemoglobin, or HB, the red cell count, RBC, hematocrit, HCT, mean corpuscular volume, MCV, mean corpuscular hemoglobin, MCH, mean corpuscular hemoglobin concentration, MCHCH, and red cell distribution width, RDW-CV. These parameters can help describe the number, size, hemoglobin content, and variation in the patient's red cells. Next are the white cell parameters.
We will look at the total white cell count, WBC, neutrophils, lymphocytes, and the neutrophil to lymphocyte ratio, or NLR. These may provide information about immune cell patterns and systemic inflammatory context, although they are also nonspecific. Finally, we will record platelet parameters. These include the platelet count, MPV, or mean platelet volume, and the platelet to lymphocyte ratio, or PLR. But here is the most important part. We are not assuming that all of these parameters predict H. pylori. We are testing whether they contain useful information. That means some parameters may turn out to be associated with the result. Some may add very little, and some may be misleading if interpreted without clinical context. The aim is not to force every result into a pattern. The aim is to observe the pattern honestly, especially when it does not behave as expected. In the next episode, we begin with patient 1 and make the first prediction.
Can I look at a patient's FBC and predict whether their H. pylori antigen test will be positive? We are starting an experiment. I will see the FBC first, make my prediction, and only afterward reveal the actual H. pylori result. This is patient 1. The clinical information is abdominal pain. Here are the important FBC findings. Hemoglobin is 15.7 grams per deciliter. The red cell count is 5.95 times 10 to the power of 12 per liter, which is flagged high in this case. MCV is 84.7 femtoliters. MCH is 26.3 picograms, flagged low. MCHC is 31.1 grams per deciliter, also flagged low. RDW is 13.5%. The white cell count is 6.14 times 10 to the power of 9 per liter, and the platelet count is 209 times 10 to the power of 9 per liter. So, based on this FBC, would you predict positive or negative? Pause here and make your own prediction before I reveal mine. My original blind prediction was H. pylori positive, with approximately 60% confidence. The reason was not anemia. The hemoglobin is normal. What caught my attention was the combination of reduced MCH and reduced MCHC. Together, those findings suggest that the red cells may contain less hemoglobin than expected, a pattern sometimes described as reduced hemoglobinization. Now for the reference result. The H. pylori antigen test was positive. So, the first prediction was correct. But we need to be careful about what this case does and does not show. The interesting feature was not anemia. The patient's hemoglobin was normal. The feature that drew attention was the reduced MCH and MCHC. However, this does not mean that low MCH or low MCHC diagnoses H. pylori. Those findings are nonspecific. They can occur for several reasons, and one correct prediction does not establish a clinical rule. One prediction is correct, but one case proves nothing. Let's test another patient and see whether the pattern holds. Our first patient was H. pylori positive, but what happens when the FBC looks completely different? This is patient 2. The clinical information includes epigastric pain, headache, and joint pain. The white cell count is 3.43 times 10 to the power of 9 per liter, flagged low. Neutrophils are 1.43 times 10 to the power of 9 per liter, also flagged low. Hemoglobin is 13.5 grams per deciliter. The red cell count is 4.46 times 10 to the power of 12 per liter. MCV is 93.2 femtoliters. MCH is 30.2 picograms. MCHC is 32.4 grams per deciliter. RDW is 13.0%. Platelets are 234 times 10 to the power of 9 per liter. The NLR is 0.92. This is a very different picture from patient 1. There is no obvious hypochromic or iron deficiency type pattern here. The red cell indices do not show the same reduced MCH and MCHC pattern that caught our attention in the first case. Instead, the most noticeable findings are the reduced total white cell count and reduced neutrophil count. So, based on this FBC, would you predict H. pylori positive or negative? My prediction is H. pylori negative. Now, let's compare that prediction with the reference result. The H. pylori antigen test was negative. The second prediction was also correct. That may feel encouraging. 2 predictions in a row have matched the antigen results. But we should not rush to conclusions. The first case had a possible red cell clue and was positive. The second case lacked that obvious pattern and was negative. This is interesting, but it is still only 2 cases. We need more observations, and we need to pay close attention to the cases that do not fit our expectations. 2 correct predictions can make a pattern feel convincing, but science becomes more informative when we test the next case honestly. In the next episode, we meet patient 3, and the prediction fails.
Our first 2 predictions were correct, so I thought I was beginning to see a pattern. Then patient 3 came along. Patient 3 presented with epigastric pain. The FBC looked largely unremarkable from a red cell perspective. Hemoglobin was approximately 14.8 grams per deciliter. The red cell count was approximately 4.73 times 10 to the power of 12 per liter. MCV was approximately 97.7 femtoliters. MCH was approximately 31.4 picograms. MCHC was approximately 32.2 grams per deciliter. RDW was approximately 13.3%. The white cell count was approximately 4.89 times 10 to the power of 9 per liter. The platelet count was approximately 310 times 10 to the power of 9 per liter. The striking finding was the eosinophil percentage, approximately 10.2%, flagged high. The red cell pattern was not obviously hypochromic or iron deficiency type. There was no clear low MCH or low MCHC pattern like the one that influenced the first prediction. Instead, the feature that stood out was the elevated eosinophil percentage. So, based on this FBC, would you predict H. pylori positive or negative? My prediction was H. pylori negative. Now for the reference result. The H. pylori antigen test was positive. The prediction failed. This is not a disappointing result to hide. It is one of the most important results in the series. A hypothesis becomes more interesting when it fails because the failure tells us where our explanation is incomplete. Patient 3 shows that a patient can have a positive H. pylori antigen result without the red cell pattern we were watching for. It also reminds us that an elevated eosinophil percentage is not a specific marker for H. pylori. It may reflect many different clinical processes, and it should not be interpreted in isolation. 3 cases have now given us 2 correct predictions and 1 incorrect prediction. That is not enough to calculate reliable clinical performance. It is enough to show why larger datasets, careful definitions, and formal analysis are necessary. The prediction failed, but the investigation improved. In the next episode, we will discuss the warning that prevents the most dangerous interpretation of all. This episode is extremely important. Here is the mistake we must avoid. Low MCH does not equal H. pylori. A low MCH may indicate that red cells contain less hemoglobin than expected, but hypochromia has many possible causes. Possible explanations include iron deficiency, thalassemia and other hemoglobinopathies, chronic disease or inflammation, other nutritional problems, and blood loss. Those possibilities cannot be separated using one FBC value alone. The clinical history, examination, additional laboratory tests, and the patient's broader context all matter. There is another equally important point. Normal FBC parameters do not exclude H. pylori infection. Patient 3 demonstrated why. A patient may have a positive H. pylori stool antigen result without an obvious hypochromic or iron deficiency type pattern on the FBC. So the absence of a pattern is not proof that infection is absent. This brings us to the distinction between a clue and evidence. The FBC may provide a potential predictor or a clinical clue. It may help generate questions, identify patterns worth investigating, or contribute information to a predictive model. But the stool antigen test is the evidence we are using for active H. pylori infection in this series. The FBC and the stool antigen test are not interchangeable. Use the FBC to generate questions. Use the appropriate test to establish infection. And whenever a laboratory pattern appears interesting, ask what else could produce the same result. Low MCH is not H. pylori. Normal FBC parameters do not rule H. pylori out.
The next question is whether, after collecting enough cases, we can test these ideas formally and perhaps use artificial intelligence to explore the data.
Once we have enough cases, we can move beyond individual impressions. We can introduce statistics. Instead of asking whether one patient's FBC looks suggestive, we can ask whether a pattern appears consistently across a population. We might begin with methods such as the chi-square test for categorical variables and a t-test or Mann-Whitney test for comparing groups, depending on the data and its distribution. We could use logistic regression to estimate the relationship between FBC parameters and H. pylori stool antigen positivity. We could then evaluate discrimination using a receiver operating characteristic curve, or ROC curve, and summarize performance using the area under the curve, or AUC. We would also want to understand sensitivity, specificity, positive predictive value, and negative predictive value. Each measure answers a different question. None should be interpreted without considering the study population, prevalence, sample size, missing data, and validation strategy. Eventually, we could compare machine learning models. The possible input would be routinely available FBC parameters, such as HB, RBC, HCT, MCV, MCH, MCHC, RDW, WBC, neutrophils, lymphocytes, NLR, platelets, MPV, and PLR. Those inputs could be provided to models such as logistic regression, random forest, or XGBoost. The model would then produce a predicted probability. For example, a model might estimate H. pylori positive, 73% probability. But that number is not the end of the process. We must compare the prediction with the actual stool antigen result. Was the antigen positive or negative? Did the model perform well across many patients, not just one or two memorable cases? Did it generalize to patients outside the dataset used to train it? This leads to the eventual research question. Can routinely available FBC parameters predict H. pylori stool antigen positivity among patients presenting with dyspeptic symptoms? That is where this investigation connects with the theme of AI in laboratory medicine. The purpose is not to replace the diagnostic test with an algorithm. The purpose is to understand whether routinely available laboratory information can contribute to earlier suspicion, better risk stratification, or more efficient clinical research, provided the model is developed and validated properly. A model probability is not a diagnosis. A high AUC in one dataset does not guarantee clinical usefulness in another setting. Before any model is trusted, it needs appropriate pre-processing, transparent reporting, calibration assessment, internal validation, and ideally external validation in a different patient population. So can AI predict H. pylori from the FBC? Perhaps it can identify useful patterns. Perhaps the signal will be weak. Perhaps the model will perform differently across populations. We do not know yet, and that is precisely why the question is worth investigating. The laboratory gives us the measurements. Statistics help us test the relationships. Machine learning helps us explore complex patterns. But clinical validation decides whether those patterns are genuinely useful. This is the journey from a routine FBC to a research question. Measure carefully, predict cautiously, validate rigorously.